I was looking at some of the stuff that I could present in a conference like this, so I thought there's something that we could share all together. I think anyone in the specialty, in the medical specialty, whether it's dental or medical, would need to know that there's something new exist that could help. We always say when we come to a treatment, we say there's a gold standard of something, the gold standard of whatever the case is. In sleep apnea, a lot of people, they used to say the gold standard of treating sleep apnea is tracheostomy, especially when you're talking about neonatal, a baby boy or a girl who just born and they're desatting, and you will see there's no chin or there's a very retruded chin. Immediately, in no time, ENT with their knife, they will just crack the trach and they will trach the patient. And it is until this minute, it's in the books written that the gold standard of treating sleep apnea in neonatal is tracheostomy. It's not anymore, at least not in a place I work at, not even where we working at the state or where a hospital, the military hospital that I used to work. Every time I move to a new hospital, I'll find a lot of people fighting this. But in a very short time of period, I changed the attitude of people because they see the result. We're talking about 10 to 20 days period of time that you can keep any patient intubated, then you take the tube out and then there's no need for tracheostomy. And we're going to talk about this. Now, as a president of the Saudi Society of Maxillofacial Surgery, being a president for 2 years, just wanted to show a little bit about it. I couldn't just let it pass without give a benefit of my society to wherever I go, all over the world. We just had our first international meeting. It was so excited. We have one of the best leaders. Every year we have a conference. Every year we have a theme. Last year, our first international, the theme was plastic, cosmetic. So we got all the kind of people that I work with in the state and the president of the American Society, the American Academy of Cosmetics. So next year we're probably going to get, our theme probably from now is going to be pathology. So probably we're inviting one of the big figures with his team to run the whole conference. In the same time, we have monthly activities. We have a lot of good, very well-trained doctors who run a training. As you must know, Saudi Arabia is a big country. So we have 3 regions, East, West, and the middle. So we run monthly meeting, most of the time monthly, not that regular, but so we have all kind of variety. We have things related to cosmetics, things related to sleep apnea. This is a guy who will talk about sleep apnea. He's an MD, an intensive care unit doctor. We have people from other hospital coming from a different region, give us sharing their experience. Dermatologists talking about facial cosmetic. So we have all kind of variety. We run courses like an update pathology. It was a great course that we run recently. I thought about business since I have no clue about business. So I thought, we got a friend of mine, Joe Kerner from Johns Hopkins. We run a very, very short 2-day course in Jeddah about business management, medical business management. I learned from this course more than what I learned in the 10 years in the state. So unfortunately, he shifted my brain that I wish if I was a businessman rather than being who I am now. But anyway. This is a very important slide. I need to get everybody's attention to this because this is the slide that you always put the slide in front of your face whenever you deal with a patient, regardless how old is this patient. Neonatal, adult, 20, 60, 80, and I treated all kind of those kind of patients. 3 days up to 60s. With a sleep apnea, I always put this in my mind. Above the nose, above the eye, there's a brain. So anything that comes from above the brain, it's not my job. We call it central sleep apnea. Somebody else have to deal with it. And they treat it. There are some medication to treat it with. Medication. Or sometimes the last solution for them is a CPAP. Anything else, you have to evaluate before you decide. It's by rolling out. Before you decide if it's a central, you have to make sure that you have to do a full examination. If this patient have a severe deviated septum, hyperturbinate, adenoid, or whatever, depending on the age, floppy soft palate, big tongue, small jaw, short neck, obese. This will affect this distance. Now, if you go and do something to the jaw or ortho alignment or anything, and the patient have a floppy uvula, you will never cure this guy. Absolutely you will not, because you didn't diagnose the right diagnosis. And I know someone, a close friend of mine in the United States, every patient who snore, every patient who UPP is uvuopalatal-pharyngeoplasty. Everyone gets, even he have a program in the radio, Dr. blah, 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 for snoring, for sleep apnea. And those people, they continue to snore, they continue to have a sleep apnea. The only thing they get back after the surgery, that they have regurgitation and hypernasally. So they, instead of talking like this, they will be talking like this, okay? Like Southern people. Southern in the state, not in Southern. So this is a very important slide. As again I said, you have to make a diagnosis. Now, to make this more simple, I go very simple in my evaluation of those patients. I always find a reason. It's always obvious there. 80% of the patient with a sleep apnea, they have their problem at the base of the tongue. Probably 15%, they have it at the palate area. And at the palate area, maybe at the high palate, maybe adenoid, maybe the uvula, depending on. If they are smoker, usually I found out that the uvula is very laxed and it's vibrating, actually. When you tell them, say, ah, you don't say, you see it. You see the uvula laying in the dorsum of the tongue, okay? So, now what is the other 5%? Can be anything else. Among of them is the central apnea, okay? Now, we know the fancy of using distraction for cosmetic reason. Now, whatever I'm going to show here, don't ever ask me, well, the patient doesn't look good, okay? Because I will never operate in somebody who's 6 years old or 3 days old or in a neonatal age for a cosmetic reason. Otherwise, I would have been in jail or in court for those cases. So I treat them to make sure that they continue to breathe. It's a life-saving procedure, or at least to make their life better, because if they get a tracheostomy, they can breathe, but they will take the risk on the sequelae complication of the tracheostomy, early tracheostomy, which is, I can list it and we will come to it, which is like a pneumonia, and for those patients usually they are in hospital setting, so they develop hospital-acquired pneumonia, which is very complicated to manage. Actually, they end by death. And another problem, which is supraglottic stenosis of the trachea, where they will continue to live the rest of their life with tracheostomy, fenestration. So, I'll try to go now faster, since now, in some syndromatic patient, the problem may be in the midface, like in Ebert syndrome and Crozon syndrome. So we're not talking about distraction in the jaw, in the lower jaw. As I said, if I see the problem, and I fortunately, out of probably 35 or 40 patients that I saw between Ebert and Crozon, and I was in a very busy center in Pittsburgh, out of those patients that I see them for this purpose, maybe 3 or 4, they have sleep apnea. So really the most common cause of sleep apnea is at the mandibular area, as I show from the slide, 80%. So there's a lot of patients with Crozon and with Ebert that they don't have sleep apnea. So those are the patients that they need to be treated, but they're treated for another cosmetic reason, probably not for sleep apnea. So we know, and we develop also a resorbable distraction for the midface, where we do a monoblock and we move the frontal and the midface with a distractor behind the ear, a metal distractor, but everything inside is resolvable, and we squeeze it and it will push the face forward. And we cure sleep apnea in Crozon and in Ebert syndrome. Since we can do this in a midface, then a mandible would be much easier, especially for distraction. Now you can talk about cases where there's nothing, hemifacial, Petrosky type 1, type 2, type 3 of hemifacial microsomia, alcoholic fetal syndrome, Ebert, Belly Robin, Nager, hemifacial, all kind of syndrome that you can see, they all have those kind of problem. And the syndromatic the patient, the more complicated the problem. I'll show you what I mean by that. But anyway, the thing is, you cannot do, unfortunately, most of those cases that I'm going to show, you will see that they have a tracheostomy already. So we're going to work on decannulating them. After they get the trach, no one could ever get them out of tracheostomy. Every time they cap it, they desat, so they keep the tracheostomy. So in a month, in a two, they are in the ICU because they develop pneumonia. And they have some sort of sepsis, blah, 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 meningitis, all kind of complication of the tracheostomy. Now, from the previous way that we treat, we have those small intraoral devices, distraction that we have. So we don't have enough advancement, because a patient like this, if you put an intraoral device, probably you have maybe, the device is 5 centimeter, you have only 3 millimeter of bone, a ramus, small ramus. So you cannot split the piece, and you cannot put the piece, because the piece will be out of his mouth if you put it. And I guess I have one of this. And after treatment, this is what they got. So the patient's still on tracheostomy. So we have also the device failure. Every time you put a small, you know, the intraoral distractor, they have 6 millimeter or 5 millimeter screws only. And by the time you're torquing, those screws get loose, device out, you cannot continue distracting. Premature consolidation, I'll tell you, you will not understand it now until I show you a case. But premature consolidation, when we do the surgery, we make a cut, osteotomy, so we can distract the patient. If the osteotomy itself, while we are distracting, we are so slow, there will be consolidation of the osteotomy. So when you try to push the distractor, you're not pushing the osteotomy area, you're actually pushing the screw or the screw out of the bone. And then you will get it completely out of the bone. It's in the soft tissue. And I will explain it in a little bit, because I didn't describe the surgical procedure. Now, if I come to an ENT and he have his knife and the patient is desatting for a day or two in the ICU, I'll tell him, please don't trach the patient. He will tell me, what do you want to do? I said, I want to put a distractor, and just give me 5 days. We used to tell him, give us 21 days. So I said, just give me 5 days, because now we learn that in a neonatal, in a 5 days, 6 days, 1 month, 3 months, 6 months, we don't do the 1 millimeter distractor. We do 4 millimeters. So in 5 days, how many millimeter I advance? 2. 5 by 4, 20. So 2. We had people that we distract them 6 centimeters, 66 millimeter. And there's a way to do it. So we want to make sure that when we do something like this, we do it very rapidly. Because you cannot keep a patient with the endotracheal tube more than 14 days, 15 days. Otherwise, they will develop stenosis of the trachea. And that's really like a hassle later on. So you want to make sure you can do something very quick. You want to make sure that you reduce the hardware failure. If you put a small screws for an intraoral distractor, they're going to fall out. Okay, you're going to ask the ENT to wait, then it's it's useless. Elimination and open bite. If you distract a baby like this, and at the end of the stage, maybe he doesn't have sleep apnea, but he have his mouth open like that. He cannot lactate. He cannot eat. So you want to come over this problem. Ability to access the bend string. Before the wire, how do I know that at the site of the osteotomy there's consolidation? The wire start to bend. So it's not moving forward. When it starts bowing like a bow, I know there's a consolidation area. I have to go and take the patient for 1-2 minutes in the OR. Give him a little bit of that beautiful gas, sniff it, chip it, open up the osteotomy again, and we can go for another 2 centimeter. We learned that after 20 millimeter, there will be always at the center consolidation. So we go and do this again. And that's why we do a planned callus re-osteotomy. We learn from our experience that almost every patient at the time of 20, 25, we start to see the anterior wire bowing, go like this. Ooh. It means it's not pushing the whole mandible forward. It is like there's this osteotomy area is consolidating. Now I know I'm talking about something a little bit mysterious because you didn't see the surgery yet, but we can get it clear. I'm not going to talk much about this because not a lot here are surgeons, but the surgery might look ugly. I'm sorry, but Tell me of any surgery that's not ugly. When you do a left foot one, if you see, I have a lot of nurses in the operating room, they faint, especially when we take the maxilla down. Like I ask them to look away, and then you hear somebody fall or something, which is fine. But this looks really ugly, even though it is a 20-minute procedure. So what we do, we take a patient to the OR, and remember, they are pediatrics, meaning, or they are neonatal. You're working in a narrow space, and they already have a jaw that is protruded. So everything is narrow. The bone is very soft. It's like a sponge. So everything, actually, sometimes when you cut with your blade, you cut the bone. You feel like your knife went through the bone because it's very soft, spongy. So we identify, we make a small incision like the obligator incision at the raphe area at the anterior ramus. We dissect medial and lateral of the ramus. We find something yellowish in the middle side, which is the inferior alveolar nerve. It is not, in a pediatric, it's not as high as ours. It's very low at the occlusion level. We identify it, and I'm going to show you. But anyway, this is how it looks. We put two pins, one just under the condyle, and one just under the canine area, very low at the eminence area. We put two wires, go through and through. This is under the condyle. We take it through and through. I know it looks ugly. I know a lot of people don't like it. I understand this. But as I said, wait until we finish and maybe you will agree. This is exactly what we see. Make a small incision like the orthognathic incision, very quick. In pediatrics, it's cute. You make incision, you go into the bone, you dissect medial and lateral, and you see the yellowish tissue, which is the preneural fat. You know this is the inferior alveolar. So I go above it, and I take my K-wire, and I push it with my hand through the skin until I see it through my incision. Then I drill it until I come from the other side of the bone. Then I drive it through the mucosa, pretonsillar area, and I drive it through the palate, and I already dissected the other side, and I take it from inside outside. So this wire goes this way. When I'm passing the wire through the palate, transpalatal, I have my finger in the back of it, just because I know there is something live there is a little bit dangerous, the internal carotid. So I want to make sure just when I drive it in, I keep it interior. I can see always the drill in front of me. Now, when you do this and you go through and through, this is your osteotomy. After I put that wire, I make the osteotomy anterior to the cut, posterior to the nerve, which is this, okay? So I have a cut posteriorly. Then I go and make another drill at the anterior area, which is, as I didn't show it clinically, which is just at even now, in pediatric it's more prominent. If everybody put his finger at the inferior border of the mandible and go up, you will feel a dip. At that depth, we go with our wire. I pass it through the floor of the mouth, take it through the other side. So we have one here and one here. Then we attach our distractor in the outside. Now, doing this, we will have to, by having a distractor hooked from here to here, we will push this segment all the way, and we will bring the jaw forward. Again, I'm saying it might look until now ugly, but just give me a second. Now, what we do is begin day one. We don't wait. Pediatric, you don't wait. In neonatal pediatric, you don't wait. If you wait 24 hours, the osteotomy that you did healed already. We distract 2 millimeter every day, and they heal. That's why we went to 4 millimeter per day. Okay? So we do 4 millimeter per day. Weekly cephalometric, we don't do this anymore. When we start the study, we were worried. We want to know where the hell is our wire is going. So we were like, even though we see it every time, we check the pin strain. Whenever we see the anterior pin goes like a bowing, we know our osteotomy area healed. We have to go and dab it with an osteotome. Re-osteotomy PRN, whenever we see that. Now, when do we decide? All those patients, we do either polysomnography or we do bronchoscopy. Some of those pediatric, you cannot, neonatal, you cannot do really a full polysomnography. So we do bronchoscopy. When we do this, the time we stopped is when we see those patients, like the maximum that we can take them forward, or if they are trached, we cap them and we see how they respond. If they're still saturating, we just immediately terminate our distractor. we always go for overcorrection, because we all know that there's always muscle pull. I'm going to say something about it later on. Remember, I'm not trying to correct a profile that I'm worried if I do this for a lady and then she will say, oh, my chin went back again. No. This patient, he will be happy, his family will be happy that he is taking oxygen, he's breathing, okay? No consolidation period. Those kids, as I said, in 24 hours, their callus is consolidated. So we leave the device, the orthodontic device, in an adult, so the advancement that we get stayed where it belongs. In pediatric, we don't do this. Now, we did more than, this is the 33, I did more than 20 in Saudi Arabia, 20 cases in Saudi Arabia since I came back. We have a lot of those cases, but they don't get referred. I'll show you one of the cases, and I'll show you how funny it was referred to me. The indication, again, clearly micrognothia, very clear micrognothia with obstructive sleep apnea. We don't operate, if somebody have a micrognothia, newly born, we're not going to do surgery for him to do the surgery just because he have a micrognothia. That's something we can worry about later on, unless he have problem breathing, okay? So that should be very clear. Tracheostomy, somebody came with a tracheostomy and they consulted me and said, well, we've been trying to cap him, we couldn't. So they send it to me. Or if they have some sort of hormonal disorder or scoliosis, that they still have some problem with breathing. Now, this is how it looks. Now, if you look at this patient, this distractor was here. So we moved this amount, almost 4 centimeter, 40 millimeter, okay? And this is immediately after, you see the open bite? This is immediately after we finish the distractor, 4 millimeter, 4 millimeter, 4 millimeter. So we distract this patient in probably 5 days, 6 days. He's all the way out. We take the patient to the OR, give him that nice gas for just 20 seconds. He falls asleep, and he already have his trach in this patient. Those who don't, it's fine. And we take it out, still have an open bite. The callus that we did, the distraction, the amount of distraction is 4 centimeter. It's a big, and it is at the raphe area. We put our thumb there, and with our index finger, we bend the bone. I know a lot of people don't like this. I know you, probably some think like you're like a butcher or something, but it's easy, it's done. So we do it, and immediately, this is after we did what I said, look at the patient. Close his, actually we pulled the chin forward and we took an x-ray. The callus is still there and their jaw are forward. Now I'm going to go a little bit faster. Now we cured almost all the patients except of 2, those who had been trached and those who had been left endotracheally intubated for more than 2 months. So it was the fault of whoever was doing this. Nobody leaves someone intubated for 2 months. If a patient in the ICU after 14 days, the ICU doctor should say, okay, are we going to wean him off from a ventilator? If not, trachea. Because if you do a tracheostomy, it's more soluble than a tube that goes from all the way along your trachea. You will get stenotic tracheal stenosis all over the length of your trachea. So we didn't have any distraction failure. The mean duration, we were up to 13. Those who went to 35 days, those are the patients who at the beginning, we didn't know about the premature consolidation, so the device went out, so we waited for 5 days, then we put the device again. They healed very quick, we put the device again. Auto-correction of the open bite, as I show you. The decannulation of tracheostomies, the sleep apnea was resolved in all of the patients, even the other 2. One of the patient with a tracheal stenosis went through a tracheal reconstruction by our ENT, and it worked. The other one never worked, because the one that was left intubated for a long time, because you cannot reconstruct the whole trachea. You just cannot. Result, no early termination of the distraction, because as I said, this device, when we put it, you can lift the baby head like this with the device, because it's going through and through. Detection of bend strain, as I mentioned, all patients required osteotomy beyond 20 millimeter. So if I go 20, immediately, we call the nurses, send the patient to the OR today or tomorrow, give him the gas, go where the osteotomy is, put the osteotome, tap it, it will open the distractor simply, and we keep going for another procedure. For hemifacial microsomia, what we do is exactly what we do for a regular patient, except for the normal side, we have a distractor here and a distractor here. We don't want to distract this side. We distract only the affected side. So what we do, we distract here 4 millimeter a day. We distract here 4 millimeter a day forward, and we bring it back. We just want to make sure that when we distract one side, we don't load the condyle in the normal side. So we make osteotomy to release the kind of, and again, we learn. We heard some kids before at the beginning, but we learned that you don't. In the past, everybody used to do a distractor on one side, and they do the distraction and they load the other side. Now this is the same patient I show you the clinical picture. This is the area where the nerve was coming up, and you remember you were able to see the Kirschen wire here. Now look at where is the wire. Now this is, I swear, it's not in the intracranial. It's not in the baby brain, okay? It's there, okay? And this is the whole amount of distraction that we got. Now, are there anything I want to show? No, that's it. This is the airway before, this is the airway. You can see the reference part is actually the epiglottis shadow. You will see it open very widely in those patients. Complication, it's very simple, little tiny things. You're talking about a track, and I'll tell you, almost all of those patients, in 2 weeks, when you have a pimples, how you flick it, I flick it out of here, it's done. It doesn't show. I'll show you clinical pictures. Transient marginal mandibular nerve, and they all return back because we do it under blind vision. We just go directly to the bone, so there's no chances of injuring the nerve. Probably it's only from hematoma. Pneumonia in one of those prolonged intubation, which is this patient I told you about. Need for subsequent distraction in one patient, airway required extreme overcorrection. Again, it is the same patient that was intubated for a long time. Most of those patients, as I said, this is Bilirubin syndrome. Again, with chronosynostosis, so what they do, neurosurgeons start immediately put a shunt to release the intracranial pressure, and we care almost always what? What is number one come in a patient care? Airway, ABCs. So we take the patient to the OR and we do the distraction. And this is the patient, no scar. This is 1 week after the procedure, no scar. We do a little bit of trick, like when I do the lower bar here, I take the skin out. So when I punch it, later on, it goes down. So it will be hidden here. So if anybody can see something, let me know. But simple. Now this is again, a Bilirubin syndrome. We do a little bit of correction. This is the scar. This is 1 week. You see the flake that I told you? You can just nip it off with your nail, and it goes away. All right? This is the amount of distraction. This distractor here was here at the joint. So we went all the way, maybe this is like 40 or 35 millimeter. This is again another, this is the patient actually I told you about. This is the one that was trached after we got her. She was intubated for 2 months. And this is the patient, we did the distraction. This is 1 week post-op, and you can see the scar went down under the chin. Now babies don't drink, but if the mother drank, they get the alcohol fetal syndrome. So the baby might born with this kind of job. They cannot lactate, they suffocate, they aspirate the milk to their lungs, and they cannot breathe. They desat, they go to 60 oxygen saturation. So what we need to do, this is the patient. This is immediately after we just pull the distractor. It's been distracted. You can see his jaw out. Now, if anybody comment and he said, but you over-distract him, he looks ugly, it's okay. I'm sorry. But we do this intentionally, okay? The patient can take, this is day 1 post-op, he can even tolerate oral intake. Immediately when we extubate him, the first few days, he was in an NG tube for feeding because he cannot. He's taking oral intake with no problem because you open the airway, everything pulled forward, the airway is completely covered. Now, this is a Niger syndrome, and this is the this is what when they use the intraoral device, nothing happened, and this is actually after 1 year. Now, this scar is not from my surgery. This is from the chronosynostosis. You can see the scar because this is the patient that was having also the shunt. In 9 months to 1 year, we have to go and open their chronosynostosis to release the pressure in their cranium. But we do first the airway. This is the sequence. This is the patient. This is when the distractor at day 1 after the insertion. This is midway. This is immediately after like 1 year after we remove it. And you can see 6 months after we did the craniosynostosis surgery. You can do this, as I said, in hemifacial macrosomia, Petrosky type 1, type 2. So we do bilateral side. This side, the affected side, we distract it. We keep distracted. This is we distract it, we put it back. We distract it, we bring it back. We distract it, we bring it back. It's only just to make sure that the pressure that we're doing when we're distracting the affected side goes at the osteotomy that we made, not at the TMJ area. This is like a costra rib graft, a cartilage graft that we did for reconstruction of the ear. Conclusion, very quick, simple and reliable, and it is simple. It is simple to the extent, well, I'm talking for surgeon. A colleague of mine who is only a pure plastic surgeon, he's not an maxillofacial plastic, so they don't work here. He's out of control now. I don't get cases referred because he's doing all of them from the Eastern Province. So it's simple. He worked 3-4 cases with me, now he's the man. So it's really simple. I mean really simple. Sometimes I get more difficult wisdom teeth. They get me sweating, and this doesn't. Okay? Serial osteotomies permit aggressive distraction. As I said, into every 20 millimeter, we just go ahead and snap the osteotomy, and we go for another 20 millimeter. No Victor planning. I don't care about Victor. We're not talking about cosmetic. No open bite, minimal scar. This is my friend. You saw his picture, actually. I invited him in our conference, Chris Gordon. He's as crazy as I, or even worse. He did his fellowship, and he called me, and I did with Fernando Ortiz Monasterio, who died 3 years ago. 2 years ago, yeah. This is the whole thing that you saw, the crazy thing. I learned it from that man, not this. We both learned it from, I'll show you his picture, Dr. Fernando Ortiz Monasterio. He's the first man ever did intrauterine cleft lip repair. This is us doing some crazy thing. Now this is a syndrome. This is the patient I showed you at the beginning. This is Niger syndrome. You can see retrognathia, you see the jaw retruded. They have missing thumb, no thumb. And everybody do this, like hide yourself and do this. Try to function with your hand, with no thumb. You cannot, really. You want to hold a pen, you cannot. So thumb, you can function with a thumb and a little finger better than no thumb with 4. Okay, so now you know why you have your thumb going a different direction, okay? You can see the airway completely closed. They have craniosynostosis, they have metopic craniosynostosis. We call it triangulocephaly. You can see, you shine the light and you will see a line of light goes in the middle because their head is like this, triangulocephaly. Now which one, where do you start? Which surgery do you want to start first? Well, airway, always airway. That's why those patients, even to intubate them, you have to do fiber optic intubation because they're not easy. You cannot go to their trachea with a tube easily. So we did it, and we did the distraction. He fell down twice out of his mother. So we kept him in house. We kept him in a hospital. Usually we teach the mother, so we kept him until we finished distraction. The second stage, we did the craniosynostosis. We opened his skull, and it's now flattened. We don't do it, by the way, for a cosmetic reason because there's intracranial pressure increase, and there's a lot of things. Then we did pulsization of the finger. We took the thumb so that he can function. I'll go very quick. So this is the patient, and it is, remember, no thumb is Niger syndrome, okay? So this is the same case. Now, this is, quickly, the cases that I did in Saudi. Foz. She is, what kind of syndrome? Treacher-Collins syndrome, thank you. A friend of mine, he's in King Faisal Specialist Hospital, the best hospital in Saudi Arabia. Do you agree with me, sir? In Riyadh? Yes. The whole team there, this patient lived 5 miles from the hospital I work in the Eastern Province. She went to Riyadh. They didn't do anything for her. They trached her. She stayed in Riyadh back and forth to decannulate her. They couldn't decannulate her. So my friend, Musad, he's a maxillofacial at the hospital. He called me, he said, I attended your lecture. We have a patient, can you, I said, how much you pay me? He said, okay, just come over. So I always go to Riyadh. Saw the patient, and I found out that they live close to my hospital. So I work in a military hospital. So we issue them an order so they can be treated in our hospital. They came into the hospital. We did the surgery. The pediatrician And the ICU patient, doctor, they told me later on, they said, God forbid, I don't know what the hell Abdullah is doing, me. Like, what the hell those things that he's doing? He's crazy, he's like showing off. Until they saw this patient walking after 2 weeks. This patient was for almost 7 months. They were trying to decannulate her. They did every kind of thing they could. In 2 weeks, she walked out of our hospital with a piece of gauze, happily with no problem. So this is what we did. So here she is. Now, you know about the syndrome, simple, very quick. Airway obstructed, there is no arch. They're missing the zygomatic arch, the malar bone, retruded mandible. They are like TCA classification 5 and 7, 5, 6, 7 classification. No zygomatic arch, you can see it completely missing. You see it? There's no arch. So, poor girl. Everybody. This is the first case I did in Saudi Arabia. I know everybody in the operating room, in the ICU, they hate me. They thought I'm a murderer or whatever, because they said it to me afterward. So this is the patient, as you can see, the distractor. Immediately I opened 4 millimeter, immediately. And then she's a little bit, second day, then she's almost finishing. We have only a few more millimeter to distract, so this joint was here. And you can see we're creating an open bite, right? That's flushed. See it? Completely. This is the day I took her to the OR to remove the device. We remove the device. And this is the distraction. Again, I swear those are not in the tooth buds, for those who care about the tooth buds. All right? This is the distraction. This is the patient, decannulated completely. No tracheostomy. She's hyperactive. She was wondering why I was running after her to take a picture. In my second lecture about this, I took the patient. I actually asked one of the company to sponsor her family to come. So the mom, the dad, and she came, and I put her on the table because it was an ENT meeting, and I knew they were ready for me. They were trying to like hunt me for something. So I got the patient on the table, and she was absolutely fine. One of the ENT who work at King Faisal Specialist Hospital, he said, we tried everything. They tried to reconstruct with cartilage, they tried to reconstruct with gold foil. It didn't work. We did distract and we put a gauze. 2 weeks, she's out. This is a chromosome 6 deletion. So those people, those kids, sometimes they say they don't survive for a year. They just die. She's a relative of one of our head of surgery department. She's a relative of him. So he told me, she's desatting. Can you do this? I said, yeah, I can do this, but I hear you talking about them if you want to take off the, like announcing as a DNR. Why should you? I mean, let's give her the best of doubt and advance her. She's, I know the patient. This is immediately after we remove the distractor. This is, I know the patient. She's 5 years old. She's a little bit mentally retarded. She's alive. Probably they used to die because deoxygenation, no oxygen in the brain. If I cut oxygen of any one of you, you're gonna die, and if you don't die, you're gonna get retarded. So this is the patient after she was almost a year or something. This is my last. This is Jenna. Cute girl, very cute girl. I got those pictures afterward because I'm a lazy in taking pictures. So after I finished treating her, I asked the dad, do you have a picture for her? Like, I need a profile. None of us take picture for his kids, a profile. I learn, I do. Now I take all my kids and I take them side picture. I don't know why, but I just keep it. God knows. So this is the patient. You can see how her chin is very retruded. This patient, every time we have cold or dust in Saudi Arabia. And we don't have dust. We don't have a lot of dust in Saudi Arabia, right? We have snow, 6 inches. But anyway, when we got dust, there's a lot of people who goes to the hospital because of respiratory problem. This patient, she come with intubation. She come immediately for intubation. And I saw her 3 times intubated. The people who used to look at me like, what the hell this guy is doing, they called me and said, can you do this? I said, yeah, we can do it. So we did the distraction. This is her. This is her immediately when we took her to remove the distractor after full distraction. This is her after we remove it. This is her. I don't care if she looks beautiful, but she's not trached. She's not trached. That's what the key. That's hair before. That's hair after. This is Fernando Ortiz Stadium. This is the guy. When we used to work there, we keep the mask in our pocket because we reuse it. Okay? So it shows you, I saw in 3 months what I didn't see in my full career, and I think I will finish my career without seeing what I saw in 3 months in Mexico with Fernando Ortiz. Probably Dr. Maria knows him very well. This is the guy. Everything is reusable. We reuse the gown, we reuse everything. If you take the hat, your head cover, there's no another one for you because they give you according to the number of the surgeon. And if you lose it, you're out of the surgery. Now, this is just a picture. I like to see that. We do a lot of things to save people, and we kill them in one bullet. Very easily, sometimes with one bullet. Thank you very much.
Thank you very much, Dr. Faidhi, for your excellent presentation and really excellent results of your work. So this paper is now open for discussion. And yeah, we will have many questions. I have one, if I may start. How many years of follow-up you have with these neonatal distractions? Because my concern is always with these neonate not to disturb growth centers. So, because it's very kind of tricky thing. That's one question. And my other question is, what about Pierre-Robin, neonatal Pierre-Robin? I would definitely prefer in severe cases distraction, compared to trach, of course. But it's tricky because they used cleft for airway, and tongue is normal, and it's obstructing actually there. So sometimes plication is kind of useful. So these two questions, please.
The last question, actually, the most frequent cases that I see, whether in the state or here, are Pierre-Robins. And actually, we have a very good result with them. They're actually the one that respond easily, and we get them because they're not very acute like other syndrome like Niger. So we catch them before they get tricked. That's number one. Number two, and God helped them. He gave them a cleft palate, so it helped their breathing most of the time when they have a cleft part of the syndrome. Now I know one case in a place where I gave that lecture, and I said clearly, don't close the cleft palate until you do the open airway, like open the airway. So they closed the cleft palate. The patient next day was dead on bed.
Yeah, that's.
So God gave them that hole to help them for a time. The second question, the follow-up. Well, the first case we did, this was done. The first case we did together with Fernando was in 2002. We presented 30 cases that was done in Mexico City and Pittsburgh. We presented in Visby, Sweden, and we presented it in France. Joseph McCarthy was there, and I was presenting. He gave me a hard time, but I was a little boy at that time. But we have a very good follow-up. Now, one thing you need to know, if I show you the last patient I showed, Jenna, remember her, sitting in the chair? I saw her after 5 years. Her chin is back. She's breathing, she have no problem. Now, everybody here, this is a failure? No, I'm not. I said clearly, I was in many places that asked, oh, well, are you happy with the results? Wouldn't you move the chin for? I didn't do this. I didn't do this for cosmetic reasons. We have problem when we are young. We have adenoid, we have puffy face, all those kind of problems that could block our airway. If I help you to bypass this by an advancement, even if it relapse, because I don't do all the measure that I do when I do an adult with retrognathia. When I do a retrognathia, severe one, I do suprahyoid muscle myotomies, blah, 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 things like that. In those kids, I don't do this. I try not to disturb the growth factor as much as I can. But I saw those patients, well, they have a problem, but we help them not to be trached, we help them not to go through the sequelae of early tracheostomies. If it relapses and if their chin goes back, well, I can catch them when they're 17. I can do lift with one, or I can do PSSO and solve the problem. Yeah.
With cleft patient again, with Pierre-Robin patient again, there's a catch-up growth. So one has to be really concerned not to indicate distractions in cases which you can manipulate by positioning and just to overcome that neonatal period, which is always the most stressful one for them. So I'm kind of conservative, not to really recommend distraction in every case. If I can manipulate without, trach, or maybe trach for a couple of days, that's fine. But if it's not, definitely distraction is helpful. And then again, surgery for cleft palate should be postponed until I have airway in place. I have mandible long enough to hold that tongue down, because otherwise we compromise very severely airway, because it's a U-shaped cleft palate, and it's really complication. Many, not only one like this one, but many of those. Okay, so I took first part of the time. So who is the first one? Do we have mic? Or you have mic?
Can I ask what do you think would happen if you distracted to the end point immediately? Do you think, in view of the age of the child, if you distracted to the end point immediately, that you would get bone growing in your osteotomy cut, bearing in mind the age of the infant?
Well, it all depends on the integrity of the periosteum around your osteotomy. When we do the flap, we make sure that our periosteum is intact. Now, if you have a bridge of bone, we learn from our experience in reconstructing that more than 10, well, it's different from surgeon to surgeon. You cannot put just a regular bone. Now, for distraction, it's different, I understand, but we never thought of it this way. We went, as I mentioned, we went as a 1 mm to 2 mm at the beginning, because we were always told that this is the distraction, how it goes, and we get failure. We get premature consolidation. Now, I understand you want me to go like this.
I accept what you say, and that we're as students, we all fall into this trap, that we have an explanation given to us when we're learning techniques that is given to us as being the truth, but it isn't always like that. And bearing in mind you're distracting 3-5 millimeters a day, something like this, which is something that isn't done in the adult patient. I just wonder if it's possible to periosteum to your endpoint, assuming that that's the case. But if it was the case, then you might avoid tracheostomies in these patients by distracting to your endpoint immediately and improving the airway in a critically ill child. And I just throw this into the pot as a suggestion to think about.
Well, remember, when we distract a piece of bone, we're also pulling other structure, like
exactly.
You're pulling the nerve, you're pulling the arteries. Okay,
exactly.
So I would assume also one very important thing to me: those patients, they are already compromised in a respiratory way. I don't want them to be in a lot of pain. If they are in a lot of pain by a lot of stretching, immediate stretching, they might, it's not a good thing to do, number one. Number two, I could affect the...
No, I accept everything that you say, but if it avoided a tracheostomy, I mean, some of these scars on the on the necks are problematic later on in life. But I'm just throwing this idea at you in the sense that if it was possible to distract to the end point without compromising the blood vessels, nerves, periosteum, etc., you may be in a situation that you'd get bony union in the distraction sites, and that you'd get an immediate effect on the airway.
Oh, we can get immediate effect on the airway by trying some of those patients by pulling their jaw. Some of those patients, we just pull their jaw forward, and the child with the chromosome 6 deletion, when we pull his jaw, I just hold it and I pull it forward, you feel he's saturating better. But would I do this surgically immediately? I don't do this. We never tried this. I understand your point, but probably you didn't get one of my point. We don't Once we get those patients before tracheostomy, now they're desaturating. We keep them intubated. So they're getting oxygen. But we keep them intubated for 10 days, 2 weeks, okay? But those that I show with a trach, we didn't trach them because we were slow in our distraction. They were trached already. They were trached, but then they asked me, then I went there and we decannulate them. We don't distract and trach. If this patient, if I start him as a new patient, I will, if he can tolerate the procedure, if he's below 90, this is our standard. His saturation in a room air below 90, he get a tube, and we do the distraction. In 2 weeks, the tube out, and everything is fine. So I'll tell you the truth. Being very aggressive in my nature, I would not do this. I think you're too much aggressive. I show you 66 millimeter. Would you pull two pieces of bone 6 centimeters away from each other? Would you?
If the child was going to die, yes, I would.
Well, he have a tube. He's not going to die. He have endotracheal tube. You see the point? So I'm not going to risk something. We were thinking that we were a little bit aggressive. I'm sure a lot of you here said, what, 4 millimeter? Because they used to teach us 1 millimeter a day, 1 millimeter a day, 1 millimeter a day.
I don't think you're aggressive. I think you're spot on with what you're doing.
Yeah.
Spot on, and you're to be congratulated
Yeah.
on the level of care that you provide.
But not 60 millimeter. But 60 is too much for me.
But it's not necessarily the final conclusion. I think that what you're doing will still develop as your experience increases.
Absolutely. Absolutely.
But you are to be congratulated. It was an excellent.
Thank you very much.
Thank you. Another question? Yes, the lady doctor over there.
Dr. Abdullah, thank you for a nice presentation. But about hemifacial microsomia, what you don't put distraction in body only and distract the body to adjust midline?
I turn off my computer, but I was worried she's going to tell me the time off. If you see, I'll turn it on. If I can catch it, I'll show it to you. If you see that hemifacial microsomia, the one with macrotia, the reconstruction,
yes.
If you saw it, actually, the non-affected side was the joint was not at its place. It was a little bit. We started to distract it a little bit and don't retain, like distract 4 millimeter and we bring it back 2 millimeter. When we start the midline, we want to correct the midline. So we were moving the other side too.
Okay, and Brzezinski class 3, some patients have no ramus and condyle.
Yeah.
How you can pass the wire from ramus to ramus other side? There is no ramus.
I'll tell you something helped me from my plastic surgery background. I do distract the digits. If somebody have amputated digit, the proximal digit,
yes.
I cut it in 2 pieces. It's too small. I cut it in 2 pieces, I put 2 distractor and I elongate it. And I send them to Bahrain to tattoo them to have a nail. Now they cannot bend the finger.
Okay.
But they have a finger.
Yes.
So aesthetically it's acceptable. If you can't distract this piece, you can distract anything else. I know Dr. McCawi also, he have the transport things, device.
Yes.
I don't do that. I distracted a lot of hemifacial macrosomia with, I can tell you literally almost 2 centimeter, like 10 millimeter. If I can get 5 in each side or 7 millimeter in each side, I will distract. I will begin slowly with my distraction. I would not go with 4 millimeter because I want to make sure that when I pull the small pieces of bone, and I will do 2 distractor in one side and 2 distractor in one side to pull
the wire pass, there is no ramus. You pass in soft tissue other side?
No, if it's completely, there's no body, no ramus, no.
No, there is, I ask about ramus. Some cases of golden heart syndrome, hemifacial microsomia, there are no ramus. So you can't pass the wire.
No, then
ask
we will,
about that.
Oh, then we will go one side.
Yes.
The old.
Without wire.
Without wire, we will go with the screw from one side, the double screws on one side.
Okay.
Not transfacial, not our technique.
But about cases of ankylosis, you can't open the mouth and see the wire.
I never went through one of those, but can open ankylosis.
Open ankylosis, you will lose the posterior facial height and may patient go in respiratory distress. There is more worse.
I never have an ankylosis neonatal patient.
Yes.
They usually are traumatic. I get pediatrics, yes.
Yes,
but
I asked about that.
I'm a big fan of correcting the TMJ problem. If there's an ankylosis, I don't do orthognathic surgery. You know, it's a controversy thing.
Yes, we do
my
distraction.
way. I do it my way. I fix the joint first. And I do the surgery. I know there's a lot of people, they do the orthognathic and then they do the joint. I don't do it this way.
Because if we make a joint first, you will lose posterior facial height, and we have cases we need trichostomy because there is backward for mandible. The respiratory distress will be more. With ankylosis case, if we start by TMG and then distraction. So we do distraction first, and overcorrection, then make ankylosis.
I really didn't get why would I lose the posterior height and why would I be worried losing the posterior height if I'm treating somebody with a sleep apnea, with somebody who's going to die from desaturation, and I don't lose the posterior height when I do GABA. If I do GABA,
we have make GABA arthroplasty in ankylosed condyles, so we lose posterior facial height. Okay.
How do you do ankylosis? How do you treat ankylosis?
We make distraction first for the body, make overcorrection, and mandible maybe in class 3, and then make posterior make gap arthroplasty. So mandible not protruded to backward.
And what's the difference if you do
because you for the
you
tongue,
lose it and then you do the distraction to the extent you want.
Yes, you make a tongue, and all the muscle genioplasty to forward first.
I see no difference really. I actually believe I will correct what I believe it's more disease first.
Yes, there's controversy in this.
Yeah, but I know it's a controversy, but you defending your point. I'm defending the way I think it is. If you do overcorrect the mandible, and then you do the gap arthroplasty, yes, and then the jaw will fold back. This is what he's saying.
But not backward and upward.
Well, it is backward and upward. This is where the condyle usually
yes,
goes.
Backward, but you make overcorrection first.
Okay. I know. I said that. You do overcorrection.
Yes.
Yeah, and then the mandible will, when you do the second surgery, yeah, I'll do the opposite. I'll do the joint because it's, yes, disease to me. I'll make, I don't see a sense for me. When you do an orthognathic surgery, when you do a distraction, you want to work with a mobile jaw.
Some cases have trichostomy first, or cases come you by trichostomy.
Say it again.
Some cases I have seen had referred to you by trichostomy, or you do trichostomy before distraction.
No. I was just saying I don't do tracheostomy.
Okay.
There's
a benefit.
Not for those. Actually, my procedure is to avoid tracheostomy.
Yes.
Yeah. Okay. So those patients who had tracheostomy, I tried not to ask the doctor not to do more tracheostomy for other patients. Let us do the distraction
because
to avoid
that's the aim of distraction.
Yeah.
One point, please, we add for Pierre-Robin syndrome.
Yes.
Pierre-Robin syndrome, we agree with you, make distraction first and then make a cleft. We have cases by 3 days or 15 days. By for Pierre-Robin syndrome, there's distractions, 5 milligram distractions. We make forward for mandible, and at the end of distraction has the angle, we correct the open bite. There are 36 cases until now we done, and we can diagnose patient need or not by pulse oximetry, and you can also make suture tongue at the base of the tongue to forward tongue forward if the patient go to cyanosis.
May I ask you guys to continue maybe in private? It was very interesting discussion. I believe we all enjoyed that, but it's kind of, individuality of each surgeon. It's what they consider the best for the patient. So
just want to correct one thing. You introduced me as Professor Abdullah. I'm not professor. I never work in a university. Unfortunately, I'm just saying I never work in a university.
I'm sorry.
I'm not a professor.
Okay, so any more questions for this one? Very quick one, maybe? If not, yes? Okay. We have the lady over there first, okay? So maybe we can take 2 quick questions.
I just want to know that what are the common malformations that you have found out in your followed cases?
Cannot hear you.
The malformations?
Yes.
I'm sure at this pretty early age, you can't really decide what are the dental malformations that occur. what are the ones you have followed up and diagnosed in your patients, the dental malformations, and how have you handled them?
Well, we did a study actually in rabbits. And our patient, those who we follow, we are lucky enough. We did hit some tooth buds in the lower. We did a lot of mistakes at the beginning, but all of them, they were actually corrected nicely in a way, especially the people who I did in the state, because I had a good follow-up. The Trocher Collin patient, I show her a case that I did for reconstruction from cranial graft, and they were so happy. They didn't call me back. I don't know where the hell they are. They changed their number. I'm running after them. I would pay them to do the case, just so I have a full sit-up.
Okay.
So, but we did a study for that reason. We induced crinosynostosis. I'm just giving you an example. We took rabbits with young rabbits, and we induced with bone-forming collagen. We have a research fellow. We induced crinosynostosis in some of the rabbits, and we treated some of them by opening the crinosynostosis, and we left some untreated. And we found a lot of shift in those who were not treated, and those who were treated, they were corrected. We found a lot of those who have malocclusion in the maxilla, in the mandible, deviation, all kind of things. So I would assume, just from the study that we did, that if you leave a small malformation, like what we see when a baby falls and we have ankylosis, if you follow him and no surgery was done, nobody took care of him, you will see malformation of the face. So I think any patient with a syndromatic problem, surely they will have some problem later on in their life. We lose track of a lot of patients. They go and follow up with their orthodontist. When we were in Pittsburgh, we don't lose any. You know why? You know who is the coordinator for our cleft lip and palate syndrome patient? She was treated in University of Pittsburgh 37 years ago when she was born in the hospital. So she was our coordinator. She's a cleft patient. Cleft lip
Okay, thank you. One more last question, very quick one, please.
Yes, very quick one. When you finish the distraction, I understand it is in small babies, I mean those you have shown. I am impressed with your technique, with your results. How long do you wait until the bone will consolidate so that you can remove the pins?
If I move the last 4 millimeter yesterday, tomorrow I'll remove the device.
So you can remove it
immediately. I told you, when we distract them 2 millimeter, they consolidate. They continue. They consolidate so fast. Even if you remember one of the pictures that I showed, some of the kids we have a bandage. We wrap them under their chin because we think we want to keep them consolidating. Then we tried not to. They're fine. They're fine. Actually, the one that relapsed, Jenna was the one, the little girl. She relapsed even though we kept her not to, like we put some bandages. They just heal like this. Yeah.
Okay, thank you very much. It was very excellent discussion and excellent presentation. And if I may ask Dr. Mark Bones to present a certificate to Dr. Faidhi.